Mm-hmm. So now we are live, right?
Yes, now we are live. Within 2 minutes, I will send you the link, and within 6 to 7 minutes, the audience will come, and then we can start directly. I would ask a permission of 2 minutes so I can handle all of this and to come back to you directly. Uh, So, Dr. Frank, do you feel that the online trend now is? I think it's the time for the online. I mean, you were having online courses before, but nowadays I think many people just focused on it. Now it become like a must or more value rather than the physical
Absolutely.
course.
Yeah.
Yes.
So
Yeah.
people before were always talking about going digital, but now there is no way around. So
Ah, yes.
you have to go digital, or you have no other choice. Yeah. So
Yes.
and sometimes
Exactly.
it has to be a point like this that the people have get pushed into maybe a new field, and I think it's also a chance. And I'm a person who always sees the good things, even in a bad situation like that. And I think this is one. So we can really grow in this digital world. We can learn how to do these webinars. We have the time now to learn, to educate ourselves instead of watching Netflix the whole time.
Yes. Perfect. So I think we have some audience here. So I would ask them, can you hear us clearly? The voice is clear. Would you please reply in the comments if the voice is clear or not?
Can you also hear me? Yeah.
Yes, yes. I think me, I can hear you, but I'm waiting their answers, not me. So let's check if it's working or not. Yes, nobody. Voice is perfect. Okay, the
Mhm.
only one. Uh, uh, it's clear. Okay, I will send you the link right now. 1 minute, please.
So the link to the Facebook group, right?
Yes, 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 exactly.
But just in case, I want to see if it's live broadcasted.
Okay, only 2 minutes, and I will finish this.
Mhm.
Yes, many people now they told me the voice is clear.
Perfect.
Perfect.
Wonderful.
So, okay, now would you please check the inbox? You will find my message.
Mhm.
You
So
can
here,
check it now in your inbox in Messenger. You will find directly the link.
yeah, looks good. Perfect.
So now let's go. So Dr. Frank, welcome back to the Egyptian community and the Arabian community. Actually, it's an honor for me to be with you on this platform. Uh, for people who don't know who is Dr. Frank, Dr. Frank, he is one of the key opinion leaders and one of the pioneer in the field of let's say the block grafts. I would say it frankly, the block grafts. If we can say who is the master who can play with the block graft and who can really document in artistic way the block graft, I would say Dr. Frank. He is the one. He is regardless his clinical skills, but you are doing a great job in photographing and documenting these cases. Dr. Frank, I would ask you something. Would you please introduce yourself to the community so they can understand who they are listening to?
Mhm. So thanks again, Ahmed, for your kind invitation. It was really a great time to meet you. I think it was 2 months ago, right? So
Yes.
that time, actually, everything seemed all right. So we heard about something going on there in Asia, but it was far away, and suddenly now everything changed. So it was really so great to meet you, to have a wonderful course with you. So thanks again. And so my name is Frank Zastrow. I'm oral surgeon from Germany. I was a former senior physician at Professor Fuad Kuri, who invented this kind of special bone augmentation. And in my presentation, I will go very into the detail to give you as much value as possible. And right now I'm here in the south of Germany in a small town called Heidelberg. It's a very nice historical city with an old castle and a very old university town. And so I'm really looking forward now to a very exciting next 1 hour with you.
Yeah. Okay, Dr. Frank, let me ask you a direct questions. I'm usually asking this to any of our honorable guests with us. Uh, uh, you are a perfect clinician. You can manage the blocks and graft in a perfect way. I think there is many dentists here. They are following you, and they are considering you as a role model. So, if you are going to give them an advice, what you would advise them?
Mm-hmm. I think it's a good question. So I'm now in dentistry since 2004, so 16 years now. When I just think back and try to remember my first steps, I think it's a quite exciting world when you enter this implantology world. And first I tried to find out which topic is actually the most interesting to me, where is my passion. And maybe this is my advice to maybe also younger dentists who are just stepping into the world, to bring passion with you. So be patient, and at the same time also patient, because many things take time. So for example, if you have the chance to meet somebody or find somebody who is really very good in what he's doing, also a role model for you, a mentor, it's important to stay with this concept for a while. I think a big mistake for many young dentists or doctors is that they are hurrying too much. They are not patient. They are jumping from one concept to the other. I think in the first beginning, it's also good to get an overview. But when you've found now, then your passion, you have to stick with this concept for a while to understand everything, because I'm not smarter than you and then maybe some others who are watching right now. The only difference to the others might be in this special field where I positioned now myself, repetition. Repetition of what I have seen. I have seen thousands of cases. I have seen hundreds of lectures about this topic. I really repeat, and every time you see it again, you will get another detail. And at the end, you have seen every case, every scenario, every complication so many times that you enlarged your comfort zone. And I think this is my advice. When you stick maybe also to a mentor, to somebody, don't jump too much. Give it a chance to implement it very deeply, and be patient, because over the time you will become very good in that. You will become an expert, but it takes time.
So, another tricky questions. When you were like 19 years old, 20, 21, I think at this time you were in the dental school, right?
Yeah.
So, would you please tell me only one thing you did at this time you feel proud and you think it affect your career after this duration?
You mean during my time as a student?
Exactly.
So, yeah, my time
Maybe
as a student actually was
smoking, maybe going outside, maybe hanging, whatever. I think there is something that.
So my student time, I think I had a quite good work-life balance. I think
Okay.
I'm much more strict nowadays with me than I was those times. So so my motto was maybe those times a little bit more work hard, play hard. So I think we had a lot of party and really a good time, and I think this is also important, not to only study. But of course, I didn't say only play hard, also work hard. I think it has always to be a balance. And nowadays, I would even say that I'm a kind of a workaholic because this is really my passion. I'm kind of addicted what I'm doing now. But those times I had more time also, and I appreciate a lot also many things next to it. Um, Maybe this is to describe it in a few
Okay.
words.
I would say this is a diplomatic answer, compatible with the community. Yes. Let's keep the reality in the private chat room, not here. Okay, so Dr. Frank, you told me you prepare like a special presentation. Would you please surprise us with the presentation?
Absolutely. So that means
Yes.
let's start with the presentation.
Yes, let's go.
Fantastic. Okay. So I will share now my screen.
Okay, and I will wait.
So here we go.
Yes.
Is it already shared?
Yes, it's already shared. Yes.
Okay. So
Oh,
you see the picture with you and me and Mohammad El Moheb
Muhammad. Yes, and that's
and
that.
Mahmoud Esad Ghazi. That was just 2 months ago. It was so great. And I think we also had a good balance when I'm thinking about that. So it was first time that
Yes.
I could see the pyramids. So much history. It was really so impressive. I really thank you once more. I think that was also perfect work hard, play hard time. So, okay, but let's go now into the topic. So, what I prepared for you is the lecture Biological Bone Augmentation. I chose this name a couple of years ago because it describes maybe in the best way the concept we are working with, because we are working with pure autogenous bone, pure real bone. And for this, I also built the group you see below, only for real bone builders. And this is the name of our Facebook group. So please feel welcome to join us also there. So the Facebook group name is Real Bone Builders. We have also a fan page with my name, Dr. Frank Zastrow. Also join us there. Real Bone Builders Facebook group has already more than 14,000 followers, and it's really growing quite fast. And because many colleagues now are also sharing their cases. And these are all cases from my daily practice. So in my clinic, we are working with 100% autogenous bone. 100%. We are not using bone substitutes except for one indication. This is in sinus. I will tell you later how we are doing it there. But in all other situations, when we have a thin crest, when we have a deep crest, whatever, we are working with a pure autogenous bone, and usually not only the particles, but also with plates. And this is my lecture now about. So in the past, I was always thinking, and also today, how to start with a lecture. And in the past, usually I started with starting with a study. Usually, when you're starting with a study, you're starting with a study that confirms or supports your own position. But all of us, we are not naive anymore. So we know that for each study we are citing, there are at least 5 or 10 other studies that say exactly the opposite of this one study. And that's why I want to start with a sentence of a good friend of mine who said this recently on a big stage. And I ask you, please don't take it word for word, but more the overall meaning of it. And he said, don't believe all studies, don't believe the guys on stage, don't believe me. Instead, only trust your eyes and your, how can I call it, your gut feeling. So, because only your own results determine your way. And what did he mean with that? I think that there are many things you read, new articles, maybe from companies, new materials, whatever, but always think twice if it really makes sense from a biological point of view. And yeah, here you see the word fail. What do I mean with that? So I think we all failed in the past. You failed, I failed, everybody. And this is always a chance to grow, to learn. Also, what I appreciate a lot, yeah, what I'm missing a little bit in these webinars is this exchange. Of course, we will have a QA session later, but I always love it to learn also from my participants, and there is not one course where I'm not learning a lot from them. And yeah, this is all about. We are coming together and we are exchanging and grow. Also, my father, he was a dentist, and he also had a lot of yeah, take-home message and learnings. And he was also one of the pioneers in implantology. So he placed the first implants 45, 50 years ago. And I think those times it was very brave, because you didn't know what if it will work and how it will work. And I'm asking you now, 40, 50 years later now, do you think we are now at a point where we know exactly what to do to come to a 100% safe result? Do we know nowadays, or let's compare it maybe with another field like a heart surgery, okay, the developments over the years. Do you think we also developed our field of implantology, in dental implantology, as much as in other fields? In my opinion, I think it's still quite challenging, and the explanation for that is this. What we have today is a surplus on information. So we have the World Wide Web, we have Google. So actually we have so much information, nobody of you and me has the time, because time is very precious today, to go through all that. Nobody has the time. And we should not forget that behind many of those informations, there are interests. And what do I mean with that? So those of you who are doing studies, you know what I'm talking about. When you're going, for example, to university clinic, you want to do a study with them, the first question will be, who is sponsoring it? Who is paying for it? And usually then you have to answer, okay, it will be this or this company. And yeah, why are they sponsoring it? I think we are not naive, we know that. So they want to have a good result at the end for selling their, for example, products. So let's say I'm here from Germany. So we have some nice cars, for example, Porsche. And imagine Porsche is doing a study, and at the end, the result is that BMW is better. So do you think they would publish this study with these results? I think not. So I don't talk about manipulation now, but at least you should always think about what you're reading, and yeah, think about who could have a benefit from it. And yeah, the more I feel actually privileged today, now with you in this webinar, to talk about a topic which has no sponsor, because there is no money to earn, because we are talking about the patient's own bone, and patient's own bone has no sponsor. But on the other side, it's a big chance for everybody who is going for this concept to save a lot of money, because yeah, it's not a billion money business behind that. It's actually for free for everybody. So you can save a lot of money by doing this concept. And I don't want to bore you with my CV, just a few words. I said already, I'm here in Heidelberg. I studied here. I was here from 2 years, 2005 to 2007, then as a research associate at the maxillofacial department in the University Clinic of Heidelberg, just 5 minutes from here. I licensed in oral surgery, and since 2009 to 2012, I was at the end also senior physician at Professor Fuad Khoury, my former mentor. And since 2012, I have my own private clinic now in Wiesloch. It's an even smaller village, just 15 minutes from here, next to Heidelberg, and we are doing their courses with live operation, hands-on, on a frequent base. And for those of you who are more interested in that, you can go and you just see it here, bba-academy.com, and you see there all information about our education. We are doing online and offline. And so usually I'm traveling a lot. Unfortunately, now I had to postpone all courses, but I really hope that soon we have the chance to continue our education worldwide. This is the group, real bone builders. Join us there. This is my Instagram account. Actually, this is even growing faster than my Facebook account now. So you see here we had 16,300 followers. This was 10 days ago. Meanwhile, we hit even the 17,000. So it's exploding. It's amazing. And I think the reason why this is exploding is that meanwhile, most of the cases are not only my cases anymore, but meanwhile from so many dentists, thousands of them, all over the world, former students who are sharing their cases. And I think this makes the concept powerful. If it's not working in only a few magic hands of some gurus, but in everybody's hands who is willing to go for it. And this concept I want to show you now in this next 1 hour is for everybody who takes this chance and also the leap of faith to maybe even also leave your comfort zone and try this new concept. Because the reason why this concept is not that popular is actually, like I said in the beginning, because there is no sponsorship behind, there's no money to earn. So that's why companies are not promoting it. And only via social media nowadays we can spread it, we can grow. And here a nice memory to the course with Ahmed Mossad. It was really fantastic. So many participants, and with hands-on cards, and many very skilled colleagues there. And I really enjoyed the time a lot. And this was the group, also with Mahmoud Esad Ghazi, and also with Mohammad El Moheb. And hope to see you all soon. This is my clinic, and we are doing their general dentistry, and not only surgery, we are doing the whole package. Me, myself, I do only the surgery with a colleague who is maxillofacial surgeon, but we do also endodontic treatment, prosthodontics. We have our own laboratory now with a milling machine. In the left lower picture, you see a group from one of our courses where we did live operation. And maybe hopefully one day I can welcome you here in one of our courses maybe. And just 20 seconds now, a small trailer from my home city. So when I look now outside, it's a little bit dark now, but actually my office here right now is exactly next to the river. You will see here, it's the river Neckar. It's a nice one, and what you see there is the old bridge from the 13th century, and then you see the old castle from the 17th century. Always very beautiful, always worth to visit it. And here is the old town with the longest pedestrian zone in Europe. So good for shopping, but not nowadays, unfortunately. And old bridge, old castle, old town, everything old. Let me ask you a question. Maybe it sounds a little bit strange, but is old good or is old bad? So at least when you're going on a congress or symposium and you look into the program, you usually don't read old technique or old material. You read instead new innovative methods or something like that. But is this more powerful than an old method? Because the old technique, I don't want to disappoint you now, but the technique I will show you now is actually 30 years old, quite old. And the material we are working with is even older. We are talking about millions of years old. Evolution, because the patient's own bone. This is how long it took here. And I think, in my opinion, this is much more powerful than any new method or any new material which comes on the market every week almost. And yeah, I'm really looking forward now to share with you this concept, and allow me also to share how I started, because I started maybe like some of you now. I was trained in GBR. And those times when I had an X-ray like that, tell me, or yeah, think about how you would solve it. And those times I was trained, if you have a hole for better healing, you have to fill this hole with some foreign material, some powder for better healing. But is this really necessary? We come to this later. And then we have some areas where we still have enough bone, because the roots of the teeth were still there. And here we can place implants maybe immediately. But the challenging areas are actually those where we don't have teeth anymore for a longer time. So maybe we have just lost here a bridge. And sometimes, you know, under the bridge, the crest is maybe sometimes like a sharp knife crest, very, very thin. And here you can show that you're a real expert, because these are also the cases which are referred to you when you are an expert, not the easy ones where you have enough bone, because those cases actually are treated by the referring doctors themselves. Easy money. But we have to have a very, very strong concept to handle those cases which are more challenging on a very, very safe base. And in these very thin crests, you see here now this concept with working here with GBR can work, but at least in my hands, it was unfortunately not very predictable, because it's only osteoconductive, and you know, this has nothing to do with vital bone, which is the topic of this lecture. So those times I didn't do statistics, but I would guess that, after the first failures occurred, I think in around 30% of the cases I had failures. What does it mean when we have 30% failures in these thin crests? That means on the other side, we have maybe 70% success. So this doesn't sound so bad anymore, right? So the question is now, do you focus on the 30% or on the 70%? Because what I realized over the years is that the colleagues are thinking differently. Some were very proud. They said, wow, even in these very difficult cases, I have more than 60% or 50% success. And others were not very satisfied, like me. I said, no, 30% failures is too much. And I think only when you're focusing on your failures and want to become better, then you can also grow. And those times I didn't know what to do else, in fact. So I knew that, some cases fail, but I didn't know how to do it better. So in fact, I was just scared. So what I did then was maybe placing implants only there where I had enough bone. But in the other areas where maybe the crest was very thin, I was too scared to do there some bone augmentation, because you know, it's not just a case or an implant, it's a human being behind, it's a person behind. It might be your mother or your daughter. And usually I think we are empathic, so you feel sorry for this other person. So each case which fails is actually one case too much, even not talking about the financial disaster, because when you have a failure rate of 30%, you can close your practice. So this is not tolerable. And so I changed my protocol in that way that I became more minimal invasive. I tried to avoid augmentation. I used more smaller and thinner diameter implants and avoided augmentative procedures. Or what else did I do those times? So what can you do if you're not able to build bone in the posterior area? Easy. Just remove the frontal teeth, and then you have enough bone to place implants there, and maybe do an all-on-4. So I said this now slightly provocative. So of course, you should not do this. But unfortunately, don't get me wrong, I think all-on-4 concept is a wonderful concept, but it should be indicated. And sometimes, unfortunately, probably you also saw this on social media, sometimes some colleagues are removing teeth here which are still okay from a periodontal point of view. And I think you would not do this, again, to your best friend. So you would try to keep the teeth, maybe some periodontal treatment, and maybe refer to somebody who's able to build bone in the posterior area. And yeah, then it was the first time that I heard about building bone with bone, so that you can also use blocks and bone for building bone. And when I heard this first time, it sounded strange to me. I was thinking, this is not possible, because I was brainwashed over the years that you need to use bone substitutes to build bone. So it was out of my mind that you could also use autogenous bone for that. So of course, nowadays I'm laughing about that, but in the former times I was really believing that. And when I also asking my colleagues what are they thinking about, they said, oh yeah, this is dangerous because there is the nerve, you can cut the nerve, so don't do this. And they also said when you're taking bone from here, a block, so this is very, very painful for the patient. And overall they said, my patients, they don't want blocks. They don't like it when you're taking blocks. So maybe you are thinking same. I was thinking then also the same, and I felt stuck. I was thinking, okay, maybe this is not the right way to go. And but then I had two situations. And like I said before, when it comes to a family member, like your mother, your daughter, or maybe a very good friend, and this was here a case from a very good friend of my family, yeah, then you're thinking differently. So she was a good friend of family, and I told you my father, he was also dentist. He was placing the implant 30 years ago. It was an old IMC implant. Maybe some of you might know this implant system. And you see, after 30 years, we had here some vertical bone loss, perimplantitis. And yeah, so she came to my father and he realized that, but those times he was already not working anymore. I was working now. And so he told to her, no problem, my son, he's oral surgeon and he can fix this easily. But to be honest, those times I was only trained in GBR. I didn't have these reliable results like I wished I have. And to be honest, I felt like this. I felt scared. So what did I tell her? I told her, first we have to stabilize the situation. We have to do prophylaxis cleaning. But what was the real reason? So I think you know it already. So I was too scared to go for explantation, take the implant out, to do bone augmentation here, and to be confronted with the vertical defect in the posterior mandible with a high muscle activity. Challenging, very challenging. So I was not ready. And then there was another case, young woman. So it was not her. This is from stock photo, but she looked very similar. And those times, it was maybe 2006 or 2007. I was working in another clinic, in a private clinic, where we were working mainly with the GBR, and my former boss there was placing most of the implants, and we were placing more than 100 implants per month, so it was like a factory. And he was always doing the same. He was trying to get primary stability in the apical area. Then he placed the implant immediately, and the exposed threads he covered then with bone substitutes. And sometimes it worked, sometimes not, but actually nobody really cared about the patient. And because it was, even when some went to the lawyer, it was even if they had to pay a little bit of money, so it was like a big money machine, all this clinic. And also at her, she was having a missing anterior incisor in the mandible. And very sharp crest, and we planned here a GBR technique, same. And also in this case, like in many others, it failed. So he exposed the exposed areas were covered with bone substitutes. It was coming an infection inside because it's quite easy to get an infection into bone substitutes, and it failed in a horrible way. Beautiful young woman, but a big recession, and it looked very ugly. And so I felt, in fact, very sorry for her. And to be honest, I didn't tell my former boss, but I blamed him for doing this to this young woman. But I'm asking you now, do you think this is fair to blame somebody when you are not having another alternative? Because I didn't have an alternative. So maybe I would have done it in a two-step procedure, maybe doing the bone augmentation first and placing implant maybe later, but this was not a real concept. So in fact, I really was angry about me because I had no better solution, and I had really this very field need now for a strong concept. And then it was really by coincidence that it was first time that I saw the concept of a split bone technique and biological bone augmentation of my now former mentor, Professor Curry, on the biggest congress for oral surgeons and maxillofacial surgeons in Germany. Also last year I felt very honored because I was also giving a lecture on this prestigious congress. And but 2008 it was first time that I saw this congress, because those times there was not social media existing, where you could see like nowadays all these cases. And when I saw first time working this concept, which I will show you now in the next 45 minutes, I was like overwhelmed. It was like magic. It looked like Photoshop. I could not hardly believe that you can come from such a difficult, compromised situation to such a perfect outcome. I could hardly believe it. So during this congress, I stepped over to Professor Curry and I told him how fascinated I was from his concept. So I took really this leap of faith. I took the chance also to introduce me to him. And I got a place in his clinic. So I stayed there almost 4 years. And this was the most amazing thing, that 80% of the cases we treated there were complication cases. That means we had pre-operations in almost all of them. Most were failing because of wrong use of bone substitutes before. And still we were able to bring almost 100% of these cases to a 100% successful result. You see here Professor Curry on the left side, on the right side Dr. Schmidt. I'm very grateful to both of them. I learned from them so much. And this was the most impressive to really see that it works not only in a few showcases like you see sometimes from some speakers. I saw this on a daily basis, that we were able to bring these super difficult cases to a 100%, almost 100% successful final result. And this really convinced me. And this was me, still with hairs. Meanwhile, they are all gone, maybe too much stress. I was senior physician then, those times. And before we are looking now into the cases I brought with me, actually, I just brought 2 cases. The first case is a combined case with lateral and vertical, and the second is only vertical. And I know many of you are interested, especially in vertical. So it's, stay with us until the second case, not to miss it. And before, I want to share with you a very interesting consensus paper. And I will show you also in a few moments why this consensus paper is so special to me, because there is something very interesting inside. So it was made from the Federal Association of Implantologic Active Dentists in Europe. And it was actually a classification. So the goal was to give a classification of defects for regular cases with bone augmentation. And it was made from many key opinion leaders from all over the world, but mainly also Europe. And you might know already maybe former classifications, like from Kaywood and Howell, 1988, or even more famous from Seibert, 1983, who described in a very good way and statistical way, in how many percentage we have which kind of defect. And what was most interesting for me was that in more than 50% of those cases, we have actually a mixed form. That means we have not only a lateral or horizontal defect, we have also a vertical defect. And this is very important to understand for the moment when it comes to the regeneration. So we need a very powerful concept and also material in those cases. And before I show you the table, I want to show you how we classify the different defects. So first we differ between a horizontal, vertical, and the combined defect, and it's a special form, the sinus. Then we differ between the different sizes of reconstruction needed, so between small, medium, and large. And finally, and this makes this classification special to me, we differ between inside and outside the contour defects. What do I mean with that? So I brought here 2 pictures with me, And on the left side, you see here the contour in blue. And you see now the inside the contour defect. That means when it goes inside the contour, we have a lot of bone walls surrounding. This is actually quite typical indication. And you can imagine that these defects are much easier to solve than the defect on the right side. Of course, these are the extremes. But on the right side, you have an outside the contour defect. That means you have to build first a new contour before you can place implants. And of course, these are the extremes. In most of the cases, you have like a mixture. So, but the left side, inside the contour, you always have to keep also in mind, for example, those of you who are doing studies, especially animal studies, or for those of you who are reading animal studies, always keep in mind that all these studies have a standardized defect. So when you're reading about a new material maybe, and they even have an animal study, actually, which is quite seldom, but if they have only inside the contour defects, so not the challenging ones. And maybe it's a little bit provocative if I say now that, many of these defects inside the contour defects would even heal without doing anything. So if you have a patient with a good regeneration potential and you do nothing, then in many cases it heals, and it's even healing worse when you put maybe also some substitutes or some foreign materials inside. So the body healing is sometimes more powerful without that, only via a blood clot. And when you see here now this table first time, it might be a little bit confusing, but that's why I want to go with you through it, and then it will be very clear. On the left side, you see the different procedures. So you see here the first group of procedures regarding the patient's own bone. So you have here the bone split, you have here the intraoral bone chips, the bone block, and the hip bone. Afterwards, below, you have the group of bone substitutes of GBR, first with only pure substitutes, and then bone substitutes together with bone chips, with vital osteoinductive bone chips. And as the last group, you see here the distraction and sandwich osteotomy, which is not the topic of this lecture nowadays or today. And here you see the different classifications. We differ between horizontal, vertical, combined as a special form of the sinus. And below that, you see -4 millimeter, 4 to 8, and more than 8, and again, less than 4, and so on. So this is the sizes. So that means small, medium, large, small, medium, large, and so on. And on the left side, all those you see here, I put a circle around it. These are the inside the contour defects, while on the right side, there are the outside the contour defects. And you see now already that sinus is only on the left side. Why? Because sinus is a typical inside the contour defect. Actually, it's the best preconditions you can imagine, because we have a surrounding of a lot of bone walls from where the regeneration can come from. So actually, it's quite simple, and you can use here we are using here also bone substitutes. And the challenging part is actually here the soft tissue management when it comes to elevating the Schneider membrane. Overall, of course, it was stated that autogenous bone is the gold standard. And before we are coming now to blocks, I want just to share one case with you, a very old case from those times when I was doing still GBR. And it's a small outside the contour defect. You see here, I was working those times with some material. I covered it with a membrane. Usually I always use tacks to make it as stable as possible, especially in those areas where we have a high muscle activity, like in the posterior mandible. And you see here now the result. And those times we had to wait maybe 6 months. And usually what you're doing when you have a result like this, what are you doing? You just do a small stitch incision. You put the healing abutment on it, and that's it, of course. But I was curious because I had this feeling that this is not the right way. I wanted to do something else, working with autogenous bone, but those times I didn't learn this concept yet. So I was curious, and from a scientific point of view, I opened the flap, and this is what I saw on a regular base. This is bone. Is it really bone? In my opinion, this is not bone. This is something, but not bone. And this is the problem. The question is also, is there a signal or an impulse that says to the bone, grow out of the envelope. To the bone says, grow out of the crest. Why should they? It's dead material. So this is the reason why, in my opinion, many perimplantitis, because it's a big topic nowadays. Many are talking about perimplantitis, and suddenly after 5 years comes the evil perimplantitis. But in my honest opinion, many cases of perimplantitis are self-made, are dentist-made. Because imagine now in this material, which is no bone, maybe you have here some pockets, maybe you have here some excess from saliva and maybe bacteria. What happens? They go through these materials through sand. There is no immune defense. There is no barrier. So, and this is the problem, and this is the reason why, maybe also we have in our clinic hardly any perimplantitis, very few, and some have really big problems with that. So I think it's sometimes self-made. And you see here the three mechanisms of why autogenous bone is the gold standard and nothing else. So you have seen this probably 1,000 times. Now you see it 1,001 times. Only autogenous bone has what we call osteoinduction. That means it initiates new bone regeneration. Also osteogenesis, that means it has the ability for angiogenesis, means building new vessels. And of course, it also works like a framework or scaffold, and we call this osteoconduction. But here comes the thing. What is the most challenging part when we are talking about autogenous bone? The most challenging part is to keep that bone alive. And of course, we cannot keep all the bone cells alive, so we are not naive, but at least a part we can keep alive. And even these cells which are dying, we are calling it apoptosis. In the moment when they are dying, they're expressing growth factors, which are again osteoinductive and osteogenetic. That means it has a total different potential, more powerful than any other materials. So this is the reason why this is the gold standard. But, a big but now. Many of you don't believe that this is stable. And this is also, it was in my mind. So the first time when I heard that you can also use bone for building bone, I thought, oh wow, this is melting like snow in the sun. At least this is always what they are saying on the education and on the courses, especially organized from bone substitutes companies. So they say it's not stable, but the problem is they are comparing this with the old technique. So what you see here on the right side is the traditional way of bone block augmentation. It's a full cortical block that was used. So this patient had a bicycle accident. So he had also a fracture of the mandible, and he got treatment in another clinic. And the same time when they did the trauma, the fracture treatment, they also built bone here in the frontal area because he has lost his teeth there. And I knew that they are working only with full cortical blocks. So the patient became then patient in our clinic and asked me to place implants there. And I told him, I don't know if this works because I knew they are working with full cortical blocks. I said, maybe we have to build the bone new. And when I really opened here the flap, I saw white bone. So it was integrated, but it was white. What to do now? To take it out? So I decided to leave it inside and place the implant just a little bit deeper, but I was not satisfied with that. But I told the patient before that this might be an option. So now it looks good, but I don't know how long it will look good. So maybe in 10 years we will have some resorption, because this is what happens to dead material. It gets resorbed from osteoclasts and microfarcs and so on. So maybe in 5 years, maybe in 2 years, nobody knows. But this is not what we want to have. This is just for fun. I called it the ivory augmentation, because it looks so white, like the teeth from the elephant. So this is white bone and this is dead bone. This is not what we want to have. And now comes the thing. Now comes the new concept. And some of you might know it already, some not. And this is why I want to describe it. So the idea is now, instead of using a full cortical block, instead we are using small particles. So we are making from this big block small particles. When we are doing this, we are enlarging the surface. That means we have faster access from the blood vessels coming there. So that means we have a faster nutrition. That means we have faster blood supply. That means these bone cells, a big part of them can stay alive because they get nutrition. And those of you who are maybe not familiar with this concept now, you would say, yeah, but this is not very stable. And this is where comes the so-called split bone technique of Professor Curry, my former mentor, comes in place. So that's why we are splitting these blocks now in thin plates. And these thin plates we are placing now on distance. This is the idea. And now we are creating like a container. This container is filled now with the particles, okay? And this is how it looks after. So this is a totally different concept than the concept before. What you have here now is red bone. And red bone means vital bone. Let me ask you one thing. If we would take now a biopsy here, what would you find in this biopsy? I'm telling you, we would find bone. What kind of bone? Are there different qualities in bone? I'm asking you. You should know that not, because this is what we all learned when we were students, when we were dental students, in physiology maybe. So bone is the only tissue in the human body which comes to its original state after healing. And I really know what I'm talking about, because my brother, he's orthopedics and emergency doctor. So, you know, in Germany, we have here Autobahn, highway, unlimited speed. So there are very, very bad accidents, you can imagine. And those guys who are surviving it, they are landing in the clinic of my brother. So some of them have 20, 30 fractures. But when they survive, it heals 100%. Afterwards, you won't see any compromised tissue anymore. It's not comparable with soft tissue, for example, where you have scar tissue afterwards. No, you have the same bone afterwards like you had before. And this is also the reason why this bone here stays now stable. Of course, you have to place implants, no question. So if you would wait now for 1 year, so we would have the same problem because no functional loading with, sometimes a bone or a residual bone. We have to place implants here to give functional loading, but then the bone stays same stable like the bone stayed before, because it's the same bone, no difference. This is maybe this is the most important take-home message. We have the same bone like here, like before, no quality B bone. It's always the same bone, it's bone, vital, red bone. And this is what we want to have. And this is what I teach you now in this next 20, 30 minutes. And but it's important to understand, especially for those of you who are new in this concept. And this is one case of two, and actually it's not starting very spectacular. We are just doing a sinus flow elevation where we were using bone substitutes, because we have here a lot of surrounding bone walls. That means that we have here an inside the contour defect. Remember the CCARD classification, the indication. And we are just covering it with a membrane. Easy, simple, nothing special. But she was a smoker, and unfortunately, after only 4 years, we met her again. But now I was a little bit too fast. Look here how it looks now after just 4 or 5 months. So you see the area where we did the bone substitutes, and you see it looks still quite still quite like bone substitutes. So, and this is the problem sometimes. You don't have a real regeneration here, even if you're waiting 9 or 10 or 11 months. So we are also calling it sometimes concept hope when we are working with bone substitutes. While now look in the frontal area where you see the screw. Here we were working with autogenous bone, and it looks like normal bone, red vital bone. And so this is how it looked after the operation. And after 4 years, the patient came to us. Unfortunately, she didn't stop smoking. She also didn't go to prophylaxis. This might also have been a reason that she has a poor regeneration potential. And she had, look here on the X-ray, some horizontal bone loss. And when we were looking intraorally, we saw that the emergence profile actually looks quite good. There was no fistula. But when we measured the pockets, we saw that we have more than 1 centimeter deep pockets. And this made us really think that the something is going on here. And when we explored that area, you see here, we also had a big fistula and a very big infection underneath. So this showed us something very serious is going on there. And when we opened fully, you see here, we saw that it was not just a little bit horizontal bone loss, it was actually something more serious. And look now on the bone substitutes. The bone substitutes look like the day before. We just could take them, look here on this picture, take them out like we just put them the day before. So no integration, no regeneration. And what we are now confronted with was actually a difficult combined vertical and horizontal defect. While look now in the frontal area, you see here we have actually a quite stable level. So the autogenous bone looks like also the day of the operation. And look here now, also again, intraorally, you still see the bone substitutes from the sinus floor elevation in the distal area. And you see here now that we have a very, very thin crest, and this is an outside the contour defect. Remember, this is not inside the contour defect anymore, like it was with the sinus. Simple. No, now we need something much more powerful, because what result would you get if you would do now the same like with the sinus, also with bone substitutes? A failure again, because when you're doing the same concept again, why do you think you would get another result? So we need now a more powerful method, a more powerful material. And this is only autogenous bone, because only this is osteoinductive and osteogenic. And you see here now the approach, how we are doing this in the retromolar area. 99% of our bone harvesting we are doing from the retromolar area, because we have a very nice balcony there. It's quite simple to take the bone from here. And for those of you who are later interested in, I will give you 40 pages of information how to do the safe bone harvesting protocol, which we invented to do this in the retromolar area. And what you see here is the use of the so-called micro saw. It's a disc with a protector, but you don't need it. Very important. So you don't need it. You can do this also with piezo surgery, but don't do it with only a disc and no protector, because this is too dangerous. So you can do this with piezo surgery. You get all the rules later in the material I will give you, but the principle is always the same. We are doing 2 vertical incision, and we are connecting it apically with 1 horizontal incision. Simple. And then what we are doing crestally is small perforations. And when you're using then a hammer and a chisel, this tension we created relieves, and the block is almost jumping out. So the distance from the border is 3 millimeter, so not more lingually. Okay, some rules important, and the incision should also be overlapping or crossing. And this is how we are taking a block. The average time for taking a block is only 6 to 7 minutes when you're used to it. It's no-brainer. And now let me answer also the one slide I started with. Maybe you remember it. When I first heard about that you can build bone with bone, I asked my colleagues and asked them, is it dangerous? And they said, it's very dangerous. But let me tell you one thing. So we did recently also another study, just from 2015. So where we did almost 4,000 bone harvesting, there was not one case with a permanent nerve anesthesia, not one. So in 10% of the cases, we might have some exposure, but never a permanent anesthesia. So it's very, very safe. It's very fast. And the most funny thing is this. Most of you are surgeons. Most of you are doing implants and doing surgery on a common base. So what are you doing when you're removing an impacted wisdom tooth? You're actually removing all that bone from the retromolar area, right? So sometimes you're making a big hole. You're destroying the bone. But on the other side, when it comes to collecting a little block, so then we are scared. So think about it. It's paradox. It makes no sense. So don't be scared when it comes to taking a block from the retromolar area. Read about the safe bone harvesting protocol I will give you later, and overcome your fear. So this is really my first take-home message. The second one is, remember when I said what my colleagues told me, that it's painful when you're taking blocks. Let me ask you one thing. Is it painful when you're placing implants? Obviously not. Why? because there is no sensitivity in the bone. So there is no difference. If you're placing something into the bone or if you're taking some bone out, there is no sensitivity. So you have no pain. This is a lie if somebody is telling you this. We are calling every patient the day after. Yes, there is some swelling, but there is no pain. And the third point is very important to me. It's a mindset thing. Many colleagues are saying, yeah, my patients, they don't want blocks. Maybe this sounds familiar to you. So my patients, no, they don't like blocks. Let me ask you one thing. So let's say you have a heart problem and you need somebody who is specialized in that. So you're going to maybe an expert in this, a specialist, and he's saying you, okay, we are having maybe two options, option one and option two, and I recommend you option two. Would you ever not follow his advice or her advice? I think not, because you realize that he studied medicine. He specialized the last 10 or 20 years in that. So he's really good. What you want is a good result. In fact, you don't care about the method. You want the result. And this is very important for you to understand. Your patients come to you because they know you're a specialist. They didn't study dental medicine. They want the result from you. They don't care about the way. So if you're telling them, like I'm doing, for example, my patient, okay, there are maybe different options. So we have maybe, you can take it from the can and use some cow bone. You can use maybe dead human body from the can or from the bottle. And the third option is we are taking your own vital bone and we are taking the bone here. Usually it comes back, very important, you should say that. And here we have usually very nice results. So there is not one question from the patient, not one. All of the patients see that I trust this concept most and follow me because they trust in me. So if they are not following you, then it's a question of trust. But they see that I trust in that. And now comes the point. The biggest enemy of you is your routine. Because it's normal, it's human nature that we are scared from something new. We are used to maybe doing GBR, even when we are knowing that it's maybe not so predictable, but we are used to it. And for taking the leap of faith, trying something new, we had to leave our comfort zone. And first, if we left our comfort zone and maybe had the first wonderful results, then suddenly there won't be, and I promise you this, there won't be, because you believe now also yourself in it, there won't be not one patient anymore who is not following you when you're saying, and for this we are taking just a little bit bone of you and we have good results. So very important now for answering this. Yeah, Ahmed, by the way, are there any questions until now I can answer maybe?
It seems everybody is concentrated in what you are saying. So it seems like if I throw like a pin, I will hear his resonance.
Okay.
So
You want me
I
to
think
follow, to continue?
I think it's guys in the page or in our watch party. If you have any question, would you please post it, and I will collect all of these questions and I will just put it directly to Dr. Frank. I know the topic is not a basic topic. It's an advanced for the advanced people. So I know that the question will not be an easy question. Prepare yourself, Dr. Frank, for a heavy question, because I know for a fact we have a lot of surgeons and a lot of skillful surgeons who are following us. So I think by the end of the lecture, we will have some question. So guys, if you have any question, would you please post it in the wall, and I will collect all of the questions and I will give it directly to Dr. Frank so we can answer it according to the lecture. Thank you. I
Perfect.
think
Maybe
you can continue, Dr. Frank.
I can add one thing. I would be very frustrated if you wouldn't have any question, because
No.
it took me 4 years to understand the concept. If you would understand now everything in 1 hour, I would feel very, very bad.
You are genius. You know, Corona generation are different. I
Fantastic.
think
Okay, let's
I,
continue.
I think we have some feedback here. They are telling just they are enjoying the lecture. I think at the end of the lecture you will find some questions, but I don't want to interrupt you every 2 minutes with a question. So I would prefer to collect them all. Then we can take one point. Okay, we can
Perfect.
proceed.
Wonderful. So what we are having here is actually the block, but you see it was not only one block, it was also two more segments, two more stripes. So you can do this after taking one block. Maybe you need some more. You can just take more stripes, because now you also see the thickness of the cortical block. And what we are doing then, we are never using the full blocks, remember. So we are splitting it. This is the so-called split bone technique of Professor Curry. And so afterwards we are scraping it, because we want to have very thin plates, and also we need the particles. That's very important. So we don't use bone substitutes, never. I know maybe some of you will ask this later, but when you're doing this technique, you're scraping your block on a glass plate, like you see here, holding it with a rongeur, scraping it maybe with a safe scraper. The amount of particles you're collecting is huge. And it's more particles than intraorally, because intraorally, always when you're using the scraper, the head and the jaw of the patient is moving, and outside it's totally rigid, and the amount will be much more. So so let's go back into the maxilla now, and what we are doing first now is placing our plates now on distance. What you have to care about is that we don't over augment the crest. So we don't have to build more than 8 millimeter of width. And you see, we are rounding the sharp edges. Should be no sharp edges existing. And also another important secret maybe, you should round all the sharp edges already extraorally, because the more you are manipulating your bone plates inside the mouth intraorally, the more risk you're undergoing that your plates might become loose, and you don't want that in no way. So you have here your container. You see, you just have to fill now the particles inside, and you understand now also that this concept is also quite fast in every way. It's super fast, because after that, I will show you later, we have to wait only 3 to 4 months for healing. 3 to 4 months, because it's already bone. This is fantastic. And second, it's much more faster than working with a full cortical block. A full cortical block, we needed to give it the right form. And here we just have to split it. Takes maybe to harvest it takes maybe 5 to 10 minutes. Split it takes another 3 minutes. Scrape it takes another 5 minutes. So usually after maybe 18 to 20 minutes, you have everything you need. You are saving a few $100. You have the best material, and you just have to place the plates and fill it with the particles, like you see it here now. And the particles go into all spaces like water. So it's really like water going in every small space, and this is much faster than working with the full cortical blocks. So some of you will think now, okay, after doing this, I need a membrane. I cover it with a membrane. And I say, no. What the hell will some of you think now? So no membrane? Why no membrane? So, and it's easy to understand if I'm telling you now this. Remember why this concept works so much better than a full cortical block. Maybe you remember. Because instead of working with a full cortical block, where the blood supply and the revascularization, the nutrition takes so long time, we are particulating it. While we are particulating it, we are creating more surface. That means we have a faster access from the blood vessels to that area. You see here, faster blood supply, and we can keep the bone alive. And this is the reason. What would happen if we would use now a membrane? We would cut the blood supply. We would get less vascularization to the bone chips. That means we would have the same problem with a full cortical block, and we would have dead material and get resorption. So no membrane. Now, how do we avoid that we have infiltration of the fibroblasts and soft tissue? Easy. We have to condense it. You have to condense the bone very nicely, and then there is no ingrowth of fibroblasts, because this is already bone. You should not compare this with bone substitutes, because bone substitutes are dead material, so they don't care what is infiltrating first. And usually the fastest material is growing inside first. usually fibroblasts, because bone takes much longer. But here we have already bone, so you cannot compare it with bone substitutes. These autogenous bone chips will never be infiltrated or never be replaced by fibroblasts. I know for those of you who are new in it, who are trained in GBR like I was, the first time you hear it, it sounds just strange and you cannot believe it. But look at my Instagram account on Dr. Frank Zastrow, where we have now more than 17,000 doctors. And most of the cases I repost there are meanwhile from colleagues, and you see the wonderful results. It really works. And yeah, for everybody who is willing to go for it. And you see here on the right picture how it looks always when we are opening it. There is no concept hope where we sometimes have like a picture that it's all not stable, that we can just scratch it, we can just scrape it away like sand at the beach, or sometimes it's super dense that we cannot even place an implant. No, this is bone like we are used that bone should look like. And in the posterior area, you still see some bone substitutes from the first sinus floor elevation. And we are placing now our implants slightly subcrestally, maybe 1 millimeter. And yeah, we have then placed in autogenous bone. And I think this is the result, what you want to have for you, for your maybe your mother, your daughter. You don't want to have some materials where you don't know exactly, does it look like a tumor or what else? This looks really natural. And nowadays, I think it's a big trend also in food industry. So everybody wants to eat something biological, natural, and not this artificial stuff anymore. And what else we did here was soft tissue management with the apical reposition flap. And you see on the right side now the very nice keratinized mucosa. And this is actually one of the two secrets. The one secret to keep your implants stable is to have them surrounded with pure autogenous and vital bone. Vital bone around implants to avoid any perimplantitis later. And the second important precondition for a good long-term result is having keratinized or fixed attached mucosa around the implants, and then you will have very, very stable results. And this is actually it's all about. And now we are coming, time is running. So we are coming already to the last case, vertical augmentation. And maybe you still remember how I started with a very special case to me. It's a very old case, more than 10, 11 years old. It's from a good friend of the family where my father placed actually the implant 30 years ago, where we have on the left side, left mandible, a big perimplantitis, big vertical defect. And after I was learning now the concept, the BBA concept, the split bone technique, I felt ready to go for this case. Because when it comes to treatment of a good friend, like here from family, you want not to give just 60 or 70% safe result, you want to give 99 or 100% result. So first we had to remove now the implant. And this was an implant which has a small basket in the apical area. You will see it's an IMZ implant. Maybe some of you know it still from the past. And what I did here was the so-called bony lid method. It's a method where you're taking the buccal bone plate out, then you can remove whatever. It can be a broken implant, can be a root or whatever. We also do this in the sinus. And afterwards, you put the block back. The alternative would have been a trephine. Trephine is also fine. But just a reverse torque wouldn't have worked here because of this small basket. I will show you in a minute or in a second what basket I mean, because here then we would have the big, you see it here on the right side, a big risk of having a fracture here, and this would even more complicate the situation. So once more, you see the bone harvesting. It's always the same principle, 2 vertical incisions or osteotomies, connecting them apically with a horizontal incision. You can do this with piezo surgery. So I use also piezo surgery usually. For that it takes a little bit longer, but you can use, for example, from Nectron or from Woodpecker. This is what we have in our clinic. And piezo surgery is fine, it's safe. And don't be scared from the retromolar area. Really, you're all surgeons. It's like removing a wisdom tooth, even easier. Just step out of your comfort zone. try it and you will see it's not a big deal. And for the rest of your life, you will have a very, very strong concept. And I tell you one thing, there is no way back. If you once start with this concept, you will never change it again, because you're saving thousands and thousands of dollars and you're giving your patients a very, very safe result. And yeah, afterwards you're splitting it. Only autogenous bone has this osteogenic potential. You see, while I'm splitting it, I'm holding it in my hand. Don't be scared. You cannot cut your finger. I did now hundreds of courses, and I never had one participant who cut the finger. It looks more dangerous than it is. You're changing then to a large disc, but you see all these details also in the material I give you later. And you're scraping it. You're holding it now with the ronger. Now you're not holding it with your fingers anymore. And look at this amount of particles. I think you're saving here. If you would pay money for this, you would pay at least $100 or $200 plus a membrane, what we also don't need. I think at least you would pay $250. And this is all money you save. And yeah, you are working with a much better material because it's osteoinductive. Then what we are doing is kind of making art. So we want to bring now this bone plate in the right form. So we remove all the sharp edges. You should do this before you're placing the plate inside. And now what we are doing is actually, yeah, the same like in lateral, but with slightly different kind. So what we are doing now is, yeah, placing one plate occlusally and one plate buccally. We are calling it the right angle technique. And I'm just stopping here. You see here the first plate, which is here placed now on distance. You see the gap we are creating, and we are creating again like a container. So same principle, we are filling this container now with the particles, with the autogenous vital bone particles only. And then another plate buccally. I just continue. And another small detail, when we are putting the particles inside, look lingually how I put my finger. Look at my finger lingually, which I push against the soft tissue to avoid that the particles are pushed into the sublingual space. Again, just a small detail, but the devil is in the details. It's also all about these small details, and then you can get also a safe result. Then you're fixing it with just 2 screws, 2 more screws, and yeah, this is how it looks after. And when you look now very carefully, you see that we didn't do a crest incision. What incision did we do? We did yeah, a so-called semilunar tunnel approach. Semilunar because it's like a half moon or C shape into the vestibule. You see here, I just stopped it, that you see it. We are not doing a crest incision to yeah, avoid here the problem of exposure. So especially when we do big bone augmentation like here, there's too much pressure from the crest then, and this could open. And with this semilunar tunnel approach, we can avoid that. And yeah, so have a look now on the X-ray. You see in the left mandible where we harvested the block. You see it's like a rhomboid. And in the you see the new level where we build the bone. You see the screws. And in the right maxilla, you see also we did here sinus floor elevation and lateral augmentation. You see also another screw. And yeah, after only 3 to 4 months, we wait never longer. So we are super fast. So we did now what we call the Kazanjan vestibuloplasty. Unfortunately, we are really, yeah, we are running out of time. I cannot go into all details, but you have to understand that we have only 6 techniques we are using when it comes to soft tissue management together associated with the bone augmentation. Only 6 techniques and actually 4 hard tissue techniques. And I will give you later the chance to learn them for those of you who are interested in learning more about this concept. And yeah, so you're opening the flap and you're seeing the nicely regenerated bone. You see here the blood vessels in the bone. So you see this is real bone. This is not like you are used maybe from GBR. So you see here hardly any resorption. When we are taking a biopsy, what you will find is bone, pure bone. The only difference you have here is it's not mature yet. This takes a couple of months longer. You see it's not mineralized yet. This is normal. So it takes maybe 1.5 years that it's totally mineralized, but still, this is super stable. And yeah, we can place now our implants. We are placing our implants slightly subcrestally, maybe 1 to 2 millimeter subcrestally. So for this, we are using implant systems with a conical implant abutment connection. And yeah, So this is the final result. This is the typical scar tissue you have after the Casangia vertebroplasty. And this is the CAD-CAM milled bar superstructure. So we do all CAD-CAM milled, screw retained. We do all screw retained. We splint it if possible. And so this is the final result. And it's a very old case, more than 10 years old, good friend of family. She's super happy with that. So in the small X-ray, you see how we started. In the big X-ray, you see the final X-ray after this situation. It's still very stable. And once more, you see here the concept of the right angle technique. So you're placing one, we call it roof plate or occlusal plate occlusally, not too much lingually, because here the soft tissue becomes too thin. And so you're filling the space with the particles. On the buccal side, you're placing another plate. You should remove then the sharp edges. So don't leave any sharp edges there. And now you have a nice support. Very important to understand, you can never do a vertical augmentation with just one plate, because then you would create a sharp edge and exposure. You have to do it always with two plates, either the right angle technique, like you see here now, or what we are having is the so-called parallel technique. You have a plate here and a plate here, and you can also give some nice support on the soft tissue. But again, not enough time now in this lecture to go through all those techniques. But just to know that we have here a wonderful concept, and we are coming already to a conclusion. So choosing wisely between the use of bone substitutes on a tortuous bone for predictable results. So you remember the CCART classification with inside and outside the contour defects. So outside the contour for reconstruction of vertical defects or tortuous bone blocks are recommended. So according to the BBA concept and split bone technique. And what you have seen at the end was the semilunar tunnel approach when we are going vertical. And with this, I'm coming to an end. And for those of you who are interested in later, I prepared a special offer for those of you who are interested in getting more information about that, how to implement those techniques into your daily practice. So just the question to you, Ahmed. Either we can continue now with the offer, it takes maybe 5 to 10 other minutes, or we are going now to the questions. Up to you.
I would prefer to say two things. I would go for the questions, but before going to the question, I have to say something. Yes, someone sent me privately, Ahmed, the lecture is amazing. Why did you make us pay for the course while you were going to give this lecture online? I was going to tell him, guys, the lecture is amazing, but the one-day course is much informative. And Dr. Frank promised me he will make a special discount for the online course, which I totally recommend for those who are interested in the augmentation. And I think after the question, you will tell us the way to register in the online course. I mean, what we had now in this live presentation, it's like 1 giga until we have like 50 giga of information and we need to extract from Dr. Frank. Thank you so much. I have some questions here from Dr. Ahmed Tuhami. The question is, what is the maximum size of the graft from external oblique line length with thickness?
So the question was, what is the maximum size?
Yes.
The maximum size is actually, I don't know if this is the right question, to be honest. So because sometimes I get this question, what is the maximum height we can build bone? What is the maximum width we can create? But in fact, this is not our goal. Our goal is not to, how can I say, to fill our ego that we did the biggest bone augmentation. It's more important to give a 100% safe result. And this also includes that we should not over-augment, because the more we over-augment, the more risk we go that we have maybe an exposure, and we want to avoid that under every reason. But still, I want to answer your question. So the maximum size of blocks we can harvest are around 5 centimeters. So very big. And when you go on my Instagram account, Dr. Frank Zastrow, you will see cases like that. And even from some participants, for example, also Radoslav Jadach, you might know him. He was taking maybe 7 centimeters. So in fact, it's amazing what you can harvest from there. But of course, this is not how you should start. In fact, you should start when you didn't do it yet with a small, I don't know on which level you are, so but with a small baby block, because also with blocks you are undergoing a learning curve. So this is also the my opinion, that you should not start with a vertical augmentation. You should do at least 20 lateral augmentation before going vertical, because you have to have some experience. And I also want to answer one thing, because recently I had it was on a course, a participant, he asked me, okay, when it comes to big bone augmentation, I understand that we need to take blocks here. But for small defects, maybe I can also stay with GBR, with the bone substitutes, right? And I was asking him, do you really think, does it make sense? Does it make sense to use bone substitute or GBR, and only when you come to the medium or large defect, you go vertical? It doesn't make sense at all, because you will never be prepared. You have to undergo this learning curve. You have to do the small defects. So you have to start with a small baby block to feel comfortable. So when the big bone augmentation comes and the big bone defect may be vertical, that you will be able, and that you can also give a 100% safe result. This is maybe also something I just wanted to add in this context.
Okay, from Dr. Muhammad Mukhtar, he say, what about the fast resorption of the cancellous bone chips?
So we don't work, very good question. We don't work with cancellous bone chips. That's the point. What we are doing is we are harvesting a cortical bone block. So very important. So I couldn't go into every detail now when it comes to block harvesting, but just get the idea. We are harvesting a cortical block, not a cortical spongeous block. Of course, we will always have some small pieces of a cancellous bone attached, and we don't waste it. But we are focusing on cortical bone mainly. So when we are scraping it, this will be all cortical block, which brings much more stable long-term results than going for cancellous bone, like we know it from, for example, from hip bone. Very good question.
Okay, from Dr. Ahmed Rafat, a great surgeon in Egypt. I want to ask, can I fix the plate with one screw? What is the minimum length of your screw?
You can. So especially when you're, nice to meet you. So when you're having a small block and maybe on one side only a screw, and on the other side you can get along with some clamping effect to avoid rotation. Then especially when you're advanced, and you are obviously, so then you can do this with only one screw. When you're slightly insecure or not 100% sure that it's super stable, then I would add another screw, because if you have only a little bit of movement, this might be enough, and then you can take the risk that you can get a failure.
Another question, how you can get enough soft tissue coverage for vertical augmentation?
So very good question. So especially in those cases where the soft tissue, we have some clear rules, where the soft tissue follow the bone defect. In those cases, we do soft tissue augmentation first. So that means we are building, for example, we have here some techniques with a connective tissue graft or with pedicle flap, building some soft tissue first to have a safe closure when it comes to big vertical bone augmentation. And also, I said it in the last case, so we avoid to have a crestal incision. There is only one exception, namely in the maxilla with a thick gingiva phenotype. Here we can do maybe a crestal incision, but in all other cases, we do tunnel techniques. So it can be a tunnel technique with the vertical relieving incisions, or the similar tunnel technique, which goes into the vestibule, like you have seen it in the last case, but no crestal incision. And then usually we have a very, very high success rate, also in vertical situations.
Okay, thank you. Another question, important question: is it better to perforate the cortical bone blocks for better healing?
So very good question, because this is probably asked from somebody who is trained in GBR like I was. And there's many studies that show that it's beneficial to do decortication or perforations in the residual bone. What we, and now comes the point, don't need with biological bone augmentation. So when you're working with autogenous bone, there is no need. So you don't need to see a hole which is bleeding to understand that it works. It works on a microcellular level. So it works without perforation. You don't need it.
Okay, thank you. Another question: if there is no bone lingually, how did you manage that? It means in the retro area.
You mean when in the retromal area there's no bone?
Yes,
There's always bone.
that's,
So
that's enough.
I had one exception in all these years. I had one case where was no bone, because there was a bone harvesting before, a big bone harvesting before, and the regeneration potential of this patient was very, very poor. So it was one case in, I don't know how many hundreds or thousand blocks I did. So there was no chance to take bone from here. But this is really a very, very, very special case, because usually you have the other side, you still have the chin, and in most of the cases you have a nice regeneration, because this is also the reason why we have so much bone here, because there is the muscle activity from the bone, functional loading actually, and this is why we have always this nice balcony. You know it when you're doing removal of wisdom tooth. You have always so much bone there. Actually, you have a surplus of bone. There is never the problem that you have not enough bone. You have too much bone.
Okay. Another question: do you recommend usage of PRF graft to cover the graft, or no membrane at all?
So in fact, honestly, we just have since a half a year PRF in our clinic, and we want to start now some studies. But until now, I didn't see the need in 99% of the cases to use PRF. Why? Because the growth factors, which you said that it's in PRF, it's already inside our bone augmentation. So we are working with vital bone chips, osteoinductive, osteogenetic, all these growth factors people are talking about when it comes to PRF is already in our bone augmentation. So the healing looks fantastic. The cover, the soft tissue looks fantastic. So still, I want to do some split mouth to see if there might be a beneficial, some benefit from it. But now comes the point, this 1% where I see an indication for PRF is in patient with a reduced immune system. For example, smokers, diabetes patient, because the healing sometimes in these patients is very reduced. And we know from PRF we also have a high amount of leukocytes here inside. And this might be helpful in these special cases.
Another important question: how the block donor site will heal?
How the donor site
will make
so
bone graft. Yes.
the block. So
Yes, exactly.
it's healing in it's a little bit similar like the question before. So usually 80% of the bone regrows. So, but of course it depends on the regeneration potential. But also in this context, sometimes there's a question: what do we have to do at the donor site? Actually, we do nothing besides putting a collagen sponge inside. Why collagen sponge? It's only for stabilizing the blood clot, but we don't use here any bone substitutes or anything inside. But usually, the bone comes back. And this is also what we are telling the patient, because obviously this is quite important for the patient when we are telling him that we are taking somebody from him or her. So if they know it comes usually back, it's good information for them.
Another smart question, actually: can we use osteodensification during implant placement if there is still horizontal deficiency? I mean, after the block augmentation, after the block augmentation, can we use the osteodensification technique in the drilling?
Yeah. So I just got osteodentification, the versatile from Salah Hubais. Yeah,
Ah,
thanks to him in my clinic. I didn't do too many cases with it. Um, I think you can do it. So I just tried it several times. So not enough to do a study with that. But I think it's a nice technique for if you want to get a more dense bone to use it. Yeah, it might be. You have to be a little bit careful. Not too much tension in this newly augmented bone, especially when you're waiting only 3 months. But after 4 months, nothing usually can happen anymore. So I think it's a good combination. But I have to do more research with it. With that.
and so now to the last question. What would you do if the particulates you got from the scraping the cortical plates was not enough?
So, so usually when a participant asks me this during the course, I'm answering two things. So
Okay.
please don't take it personal. So because we don't know each other yet, so how we will usually in the course, you are already laughing, Ahmed, yeah, you know. So the
Yes.
answer is usually two things. Either your block was too small, or second, you were too lazy to scrape. Yeah,
Very
usually,
smart
like I
reply.
said before, when you're learning these techniques and becoming good in this and going through this learning curve, you will never have this problem that you are not having enough bone. Your blocks will be big enough. And of course, you have to scrape enough, but then there is no need to use any other material. So I never use any other materials besides that. And usually, I actually have always a surplus on bone chips, and so are also all doing others who are starting with this concept or doing it for a while now.
Okay, I think this was the last question, but it popped up here to me another important question, and I would say this is the last one from Dr. Sam Omar. Dr. Frank, why do you prefer to use rhomboid shape rather than rectangular shape? Is it due to the external oblique ridge anatomy, or it's because it's more versatile?
This is, I never had this question, and
For
I
this reason, I
many questions.
insist
So
to say
it's
it.
a very, very smart question. It's very good. And the answer is already exactly inside. So because you ask, does it have to do with the anatomical structure? And this is exactly the answer. Especially when the nerve is slightly more superficial, we don't want to go with our distal incision into the ramus. Because in the ramus, the ramus is very thin. So that means the nerve is here more superficial, and then we might have the small risk that we come too close to the nerve or maybe even injure the nerve. And we want to avoid that under all circumstances. But when you are more advanced, maybe if you have a CBCT and you have some experience and you see the how the nerve is going, then you might also change to a rectangular. But this is for more advanced. So the most important thing is we want to avoid to go into the ramus what we had to go when we would use a rhomboid. Yeah. Sorry, when we would use a perpendicular.
Okay, another important question come to me. I asked last case you put two blocks, buccal and crystal. What about lingual side?
So you mean vertical? So one buckle and the other one was?
She said, Dr. Shireen, you put buccal block and crystal block, but no lingual block.
Exactly. Yeah. So this has
Why?
to do with two things. Very good question. So first of all, we do this with a semilunar tunnel approach, doing the incision in the vestibule. That means we don't get there to the lingual part. There is no space. This is one reason. But the second reason is also that there is no need to place another plate lingually or palatally because there is no movement. So on the buccal side, we have here the muscle masseter, and also in the maxilla, we have here some movement from the muscle fibers. But lingually, we have hardly or no movement, and this is also why we don't need here stability via another plate. The stability comes from the tension of the soft tissue, and usually this is enough.
Thank you so much, Dr. Frank. So now surprise me with the offer you have for the online.
So thanks for giving me this opportunity. So only for those of you who are interested, of course, maybe some of you are not interested or just wanted to see what is possible. But for those of you who are really interested in implementing those techniques into their daily practice, maybe I brought something to you because I know that it's not possible after 1 or 1.5 after a lecture to implement it in your daily routine. And I think some of you might feel now like this, really overwhelmed, too much information. And this is how I felt first time when I saw a lecture about that. And I said already before, I want to show you now here my offer. So we are doing our courses. Also recently we did it together with Ahmed in Egypt. And I do also my courses here in Germany. And it's a 2-day course. And it's first time now, because of the crisis, that we put the content of this offline course, of our VIP course, from the Real Bone Builders course, into an online content. So usually the prices here for our content of our course are 3,190 euro in Germany. And so the value of this online content, now we charge 800, or we say it's 890 euro because it's only, let's say, digital.
That's really generous from you. Thank you, Dr. Frank, for this.
So what is the content now from it? So what is the idea in it? It's 6 modules, and this contains the CCA declassification. It's the safe bone harvesting protocol. It's almost 6 hours of really all the details you've seen before. It's about the soft tissue technique, the complication treatment, so how to create the maxilla, and also the management in the aesthetic area. And still, probably some of you might think this is that you are not able to do it. And this is why I want to tell you that this concept really works for everybody who is willing to go for it, not in a few magic hands. So really give it a try. And this is Adnan Rehman, a good friend of mine.
I would say that if you're serious about bone building and want something far more predictable and safe for your patients, this is the course to come to. Auf Wiedersehen.
So, and this is also what I said in the beginning. This is my Instagram account. Please go on my Instagram, Dr. Frank Zastrow. And 80% of the cases, meanwhile, are not only my cases anymore, but from cases from so many colleagues who have really, the presentation was just crashing down. 1 second, I will go in it again. 1 second, something was wrong with the presentation, but I will be back in 10 seconds. Do you see it now?
Yes, clearly.
You see it? Perfect. Wonderful. So, and you see, all this in the Instagram account. And in our course, we also have the recordings of the live operations. So another value from 690 euro.
Our live operation, so the participants can see this via live stream here from the classroom, even ask questions.
Because then you can really go step by step also through our live operations. And so I was thinking how to put all this inclusive, in an all-inclusive solution. And what I created now, I was really working a lot about this. So it was a VIP membership. So, and all the online VIP contents are inside the live operation recordings, the benefits, and it's all inclusive now. And here you see a little bit insights.
So welcome. So finally we made it on our My Implant business platform. You will see all you need to become a real bone builder. Our courses, our online shop, but very new, our VIP membership. So let's have a look on it. So you will get live operation recordings, a lot of more benefits. And when we have a look now to one of our 6 modules, you see here the safe bone harvesting protocol. And while I'm hammering, the assistant is holding the chin. This is quite important. And on the other side, the patient has a biting device. In those cases, when the block is not coming out in that moment when you're at the chisel, in 90% it's because you don't have this overlapping of the incision. So this is quite important. And the second mistake that can be done could also be the wrong angle of the perforation, but I will show you also on the whiteboard. Okay, 1 to 2 millimeter, usually nothing can happen, and still you are able to take out the block. And here in this area, again, you're safe again. Okay, so this is the protocol for safe bone harvesting from the external oblique. And of course, here you do the perforations. So you see, all little tips and tricks you need for accomplishing these methods.
So almost 6 hours, really all that content, and also more benefits, also discounts on our upcoming courses and also our upcoming symposium with a value of 590 euro. So meanwhile, we are at 2,170 euro, the value. And one more thing I really want to add.
These guys are doing is very remarkable. They seem to have fully cracked the code on significant bony reconstruction.
I'm not really satisfied with the GBR results, and that's why I wanted to try something new, to get to know, to broaden my knowledge with bone blocks, and to gain the knowledge how to achieve very predictable results.
Yeah, like you said, the one participant before, we cracked the code, and I want to give you the code. The code is actually the ebook. It's 40 pages of safe bone harvesting protocol from the external oblique, really step by step, and together with a value from 2,339 euro. And here you see the book.
Including in this membership, you see also our safe bone harvesting ebook. You see here all the tips and tricks you need to fulfill these methods. So pages and pages full of all these little tips and tricks. You need how to take blocks, how to overcome all the challenges, what is important to know when it comes to the nerve, and so on, to have a 100% safe bone harvesting. So overall, go now to My Implant Business, go on the VIP membership, become a VIP member, and hope to see you there soon. Bye, Frank.
So in this ebook, actually we can call it a little bit like the code, but of course I don't want to charge now these 2,339 euro. But I want to ask you a question. So if you would save so much money now, and if you would get these predictable results like I showed you now, do you think at least it would be worth it? And if you would be now empowered with all the tools, the code and the checklist to do, would it be worth it to you? And here you see again the content, you see the value, the recordings, the bonuses, the ebook, and but of course I told you this is not the price I want to charge, but I ask you, what would it be worth to you? Maybe you can tell me what, if you would master now, if you would be mastering this powerful concept, what would it be worth to you?
Share everything, tips and tricks and all that stuff that can make the difference.
So I suggest this course for everybody who would like to start to work with a real bone.
I will definitely try to change my methods of augmentation for his way.
I recommend this course for any oral surgeon who would like to make upgrade for his level of surgery.
I think overall was something fantastic. I would highly recommend this to everyone to come to this training.
Oh, there was a mistake. It was Tarek. I mixed the names.
Yes,
Sorry for that.
No.
So it was too fast. So actually, the final price I want to give you, is 699, and now it's up to you. So either you say, you don't.
We will not be able to make courses anymore.
So there are actually two chances now. Either you say, you do nothing now, but then probably you will never be able to to implement those techniques really into your daily practice.
It's really a reasonable price.
It's I think it's a chance. You can give it a try. And for this, you have to go here on this page, bba-academy.com/membership. And I promised you, I also want to give you also some, especially for this group of this webinar, a discount. And we created now a discount code. So it works for only 12 hours. So there will be a countdown running down. And when you put now BBA minus VIP minus 10, you will also get a discount of 10%, and then you will get it for 629 euro. And I think it's not only that it took me now more than 10 years to develop this and that it has really a big value, but it's also about saving really, when you count it together, really thousands of dollars. So just let's count it 1 month. So let's say operation, the materials cost maybe 2 bottles and membrane $250. And you do this maybe twice per week. That means 8 operations per month. We are having already cost from $2,000, which means in 1 year, $24,000. That means in 10 years, and actually this is what I saved, and probably much more, maybe $1 million, in only these biomaterials, not using, but only the patient's own materials, which is much more powerful because it's also inductive. And finally, I told you, so when you're working with this concept, I think there is no way back, because you will see the beautiful results. And when you are able to handle these very difficult situations, you can position yourself as a well-known expert in the field of dental implantology. You will actually rise your reputation among other doctors, and you will be the one who can take very, very advanced cases with very predictable results. So I think it's worth it. And once more, thanks for watching. For those of you who are still online, so it's late now. Thanks for this. And Ahmed, this is
thank you, Frank. I'm really impressed with the offer and with the presentation.
Thank you.
I would appreciate if anyone would like to contact, you can go directly to bba-academy.com/membership. And if you just forget the discount code, send us on the messenger or in the page, or directly to Dr. Frank, and we will give you the discount code. Thank you again for your attention. Thank you, Dr. Frank, for this generous information, and wish we can see you soon without this corona, and hopefully physically we can meet soon.
Absolutely. I'm really looking forward to see you soon, my friend.
Exactly. Have a good day. Good night, Dr. Frank. Good night.
Good night. Bye-bye.
Goodbye.